Hello, my name is Sandy Ghobrial. I'm a student at Massachusetts College of Pharmacy and Health Sciences, and today I will be speaking about diabetes type 2. My objectives for this presentation is to describe the pathophysiology and prevalence of type 2 diabetes, identify the risk factors and complications of type 2 diabetes, review the most updated guidelines and discuss the most commonly used oral anti-diabetic agents, and to discuss the DECLARE 58 trial. For the pathophysiology of type 2 diabetes, it's a combination of decreased insulin secretion by the beta cells in the pancreas and increased insulin resistance by the peripheral body cells. Now, the pancreatic beta cells lose function by time in diabetic patients, and that could be due to glucotoxicity, lipotoxicity, insulin resistance, advanced age, family history, and incretin hormone deficiency. Now, there are several mechanisms that exacerbate hyperglycemia in diabetic patients. Those mechanisms include blunted secretion of incretin hormones, which are GLP-1, also known as glucagon-like peptide 1, and GIP, also known as glucose-independent insulinotropic polypeptide. So in healthy individuals following ingestion of a meal, blood glucose rises as a response to that glucose rise. Incretin hormones are secreted from the intestinal mucosa. Now, those incretin hormones, they have four effects, which are increased satiety, slow gastric emptying, stimulate insulin secretion, and decrease glucagon secretion. But in diabetic patients, due to chronic elevation of the blood glucose, there's a decreased sensitivity or a blunted effect of secretion of those incretin hormones. The second mechanism is the resistance of liver cells to insulin. Now, when liver cells are not sensitive to insulin, they do not recognize changes in blood glucose levels following meals. So they continue to secrete glucose, furtherly elevating the blood glucose level. The third mechanism is restricted uptake of glucose by skeletal muscles. So in healthy individuals, a large portion of the prandial glucose is taken up by the skeletal muscles, mainly the leg muscle. Now, an increase in insulin secretion promotes glucose uptake by those skeletal muscles. But in type 2 diabetic patients, the skeletal muscles, they become resistant to insulin, and there's a delay in the glucose uptake. And the amount of glucose withdrawn by skeletal muscles is usually reduced by 80% than in healthy individuals. The fourth mechanism is chronic elevation of circulating free fatty acids, impairs insulin secretion and increases insulin resistance in muscle and liver cells. Now, in healthy individuals, lipolysis occurs during fasting to release free fatty acids from adipose tissue. The free fatty acids are released in the blood. This process is inhibited upon ingestion of a meal due to insulin release, which inhibits the lipase enzyme responsible for lipolysis. Now, in diabetic patients, due to insulin deficiency, the process is not inhibited, and free fatty acids continue to be released in the blood. Chronic increased levels of free fatty acids leads to decreased insulin sensitivity in liver and muscle cells to insulin. The fifth mechanism is insulin resistance and is proportional to increased visceral adipose tissue, which is also known as VAT, which is reflected by the waist circumference. Now, an increase in the adipose tissue, in the visceral adipose tissue, stimulates the production of tumor necrosis factor alpha, interleukin 6, angiotensinogen production, plasminogen activator inhibitor I, and resistin. Now, those hormones, they contribute to increasing the insulin resistance by the cells, and they also elevate blood pressure and increase coagulability of the blood. Now, the sixth mechanism is continuous glucagon release. Now, due to insulin resistance, insulin deficiency, and incretin hormone resistance, glucagon release is not inhibited after a meal, which provides continuous release of glucose by the liver, worsening hyperglycemia. Now, the seventh mechanism is elevated renal threshold to glucose excretion. Now, 90% of the glucose filtered through the kidney glomerulus is reabsorbed in the proximal tubules by the SGLT2, which is sodium glucose cotransporter 2, and SGLT1, which reabsorbs about only 10% of the filtered glucose. Now, in healthy individuals, the renal threshold of glucose excretion is about 180 milligram per deciliter in healthy individuals. Now, in type 2 diabetics, the renal threshold increases from 180 to 220 milligram per deciliter up to 240 milligram per deciliter. And this is due to overexpression of the sodium glucose cotransporter 2. And this also participates in causing hyperglycemia. This is a diagram showing all the processes that I had explained, and it also shows where each of the anti-diabetic agents act. Now, for the epidemiology of diabetes, about 34.2 million were diagnosed in 2018 with diabetes. 7.3 million adults were unaware that they had diabetes when they were first tested. In 2017, about $327 billion were spent on the treatment of diabetes. Risk factors for diabetes include age of 45 years or older, a family history with type 2 diabetes, certain races, which include African American, Hispanic or Latino, Native American, Asian American, Native Hawaiian or Pacific Islander, being obese or overweight, which means a BMI of 25 or more, a sedentary lifestyle, a history of elevated A1C or impaired glucose tolerance or elevated fasting blood glucose level, and a blood pressure of 140/90 or above. Also, an HDL of 35 milligram per deciliter or less, and triglycerides of 250 milligram per deciliter or more also participates in causing diabetes. History of gestational diabetes or delivery of a 9-pound baby. Vascular disease such as myocardial infarction, ischemic stroke, peripheral arterial disease. Presence of acanthosis nigricans, which is characterized by a dark, thick, and velvety skin around the neck or armpits, and polycystic ovarian syndrome. Complications of diabetes include diabetic nephropathy, diabetic retinopathy, diabetic neuropathy, and microvascular complications. Renal function should be assessed annually in type 2 diabetics. In patients with urinary albumin of more than 30 milligram per gram of creatinine or a GFR of less than 60 ml should be monitored for kidney function twice a year. Sodium glucose cotransporter 2 inhibitor, they slow down the kidney disease progression in type 2 diabetics, and they're recommended in patients with GFR of 30 mL or more, or a urinary albumin excretion of 30 milligram per gram or more. And they're found to be very beneficial in patients with a urinary albumin of 300 milligram per gram of creatinine. Blood pressure of less than 140/90 millimeters of mercury was shown to slow down the progression of kidney disease. Um, Patients should be screened with a dilated and comprehensive screening for diabetic retinopathy at diagnosis of type 2 diabetes. And if the patients were not found to have retinopathy complications, a follow-up screening should be done every 1 to 2 years. Now, patients should be screened for diabetic neuropathy um, upon diagnosis of type 2 diabetes and annually thereafter. A comprehensive foot evaluation should be done annually. The clinician should inspect the skin. Uh, they should inspect for foot deformities and neurological assessment done by a 10G monofilament. They should check the temperature of the foot, check for ulcers, calluses, and corns. They should check the pulse in the leg and feet. They should check for a history of amputation, and they should check for poor peripheral circulation. And the clinician should also check if the patient has any amputation risk factors, which include cigarette smoking, poor glycemic control, peripheral neuropathy, peripheral artery disease, visual impairment, chronic kidney disease, foot deformities, corns and calluses that could turn to ulcers, and history of foot ulcers and amputations. Specialized footwear or they're actually known as diabetic shoes. They are recommended for patients with poor peripheral circulation or amputation history, foot deformities and ulcers, or severe neuropathy. Okay, so the American Diabetes Association guidelines were updated in 2020. Oral anti-diabetic medication drug classes that are most frequently used are biguanides, sulfonylureas, thiazolidinediones, also known as TZDs, dipeptidyl peptidase inhibitors, also known as DPP4, and sodium glucose cotransporter 2 inhibitors. This is the algorithm for the ADA treatment guidelines. First line therapy agent is metformin with weight management and physical activity. And then depending on each and every patient individualized case, then we follow a certain path of the guideline. Say for patients with atherosclerotic cardiovascular disease, glucagon-like peptide 1 receptor antagonists or SGLT2s are the ones that are preferred. For patients with a heart failure or chronic kidney disease, we have the SGLT2s. They are preferred because they have because they benefit in heart failure and chronic chronic kidney disease. For those patients, we need to avoid the thiazolidinediones because they exacerbate heart failure. We have the SGLT2s and the GLPs. They could be used as a combination. Dipeptidyl peptidase 4 inhibitors. They could be used if the GLP-1 receptor agonist cannot be used. GLP-1 receptor antagonist cannot be used. Patients could also use basal insulin or sulfonylureas. Now, if the patient gets a lot of nocturnal hypoglycemia, then we have the DPP4 inhibitors or GLP-1 receptor antagonists. We have the SGLT2s and the thiazolidinediones are the ones that are preferred because they do not have a high risk of nocturnal hypoglycemia. And then they could be used as a combination of, if the A1C target level is not reached. And then if the patient needs to lose weight or to minimize weight gain, then SGLT2s could be used, or GLP-1 receptor antagonists could be used. GLP-1 receptor antagonists, they have showed good efficacy for weight loss. And then, say if the patient is not covered under a good health plan, or if they are self-pay, we could use sulfonylureas or thiazolidinediones because they are a cheaper option. Okay, now to our drug classes. We have biguanides, which include metformin. It's a first line for pre-diabetics and type 2 diabetic patients. Metformin decreases hepatic glucose production and intestinal absorption. It also increases intestinal insulin sensitivity in peripheral cells. Metformin exists as an immediate release form, which is taken as 500 milligram by mouth twice daily, or 850 milligram by mouth once daily, to a maximum of 2,550 milligram by mouth over 3 divided doses. Metformin also exists as extended release form that can be taken as 500 milligram once a day with the largest meal, to a maximum of 2 grams taken by mouth over 2 divided doses. Metformin decreases the A1C by 1.5 to 2%. It has a low risk of hypoglycemia. The weight change caused by metformin could be neutral to some weight loss. Adverse drug reactions are mainly related to the GI tract, which include nausea, vomiting, and diarrhea. Metformin could also be associated with lactic acidosis. It's contraindicated in patients with a GFR of less than 30 mL per minute. Sulfonylureas, they are second-line agents. They are known as insulin secretagogues, and they do that by binding to the SUR1 receptor. Sulfonylureas include glyburide that could be started at 2.5 to 5 milligram by mouth daily. Could be titrated to it could be titrated at the rate of 2.5 milligram per week to a maximum of 20 milligrams per day. We have also glipizide, immediate release, started at 2.5 to 5 milligram by mouth daily to a max of 40 milligram daily by mouth. It also exists as extended release, 40 milligram by mouth daily. We have also glimepiride, 1 to 2 milligram by mouth daily. It could be titrated by 1 to 2 milligram every 1 to 2 weeks to a maximum of 8 milligram per day. Sulfonylureas decrease the A1C by 1.5 to 2%. Adverse drug reactions include hypoglycemia and weight gain. Sulfonylureas should be taken before meals to minimize the risk of hypoglycemia. Third class will be the TZDs, or thiazolidinediones. They are known as second or third line agents. They decrease insulin resistance by binding to the peroxisome proliferator activator receptor, gamma, in the liver, skeletal muscle, and adipose tissues. TZDs that we have are pioglitazone, which could be started at 15 to 30 milligram by mouth daily to a max of 45 milligram. It is, let's see here, yeah, for patients with class 1 and class 2 heart failure, we should not exceed 15 milligram daily. Another TZD is rosiglitazone, and that could be taken as 4 milligram by mouth daily or in 2 divided doses to a maximum of 8 milligram daily. TZDs decrease A1C by 1 to 1.5%. Adverse drug reactions include weight gain, fluid retention, bladder cancer, especially with pioglitazone, and increased LDL, especially with rosiglitazone. TZDs have a black box warning that they exacerbate heart failure. They are contraindicated in class 3 and 4 heart failure. Another class that we have is the dipeptidase 4 inhibitors. And let's see here. So they work by inhibiting the DPP4 enzyme, prolonging the GLP-1 and GIP half-life. The FDA-approved DPP4s are sitagliptin, taken as 100 milligram by mouth daily. So we have saxagliptin, taken as 2.5 milligram or 5 milligram daily. We have linagliptin, 5 milligram by mouth daily, and alogliptin, 25 milligram by mouth daily. They could all be taken with or without food. We have renal dosing considerations with alogliptin. If the patient has a creatinine clearance of 30 to 60 mLs per minute, patient should be taking 12.5 milligram daily. If the patient has a creatinine clearance of 15 to 30, they should be taking 6.25 milligram by mouth daily. To saxagliptin, if the GFR is less than 45 ml per minute, patient should be taking 2.5 milligram daily. Sitagliptin, if the patient has a GFR of 30 to less than 45 ml per minute, they should be taking 50 milligram daily. And if a GFR of less than 30, patient should be taking 25 milligram daily by mouth. For linagliptin, no renal adjustment dose is needed. DPP4s, they decrease the A1C by 0.5 to 0.9%. The adverse drug reactions for DPP4s is that they increase risk of hospitalizations in heart failure patients. All DPP4s, they have a risk of pancreatitis, joint pain, and respiratory infection. Then to our SGLT2s, they promote renal glucose secretion by inhibiting the SGLT2 cotransporter. The available medications are canagliflozin. We have to assess the kidney function and albuminuria prior initiating therapy. If the patient has a GFR of more than or equal to 60 mLs, patient should be taking 100 milligram by mouth in the morning prior to the first meal to a maximum of 300 milligrams per day. If a patient has a GFR of 30 to 60 ml, patient should be taking 100 milligram by mouth prior to the first meal. And if the patient has a GFR of less than 30, we should not initiate the canagliflozin. And if the patient has albuminuria of more than 300 milligrams per day, we could continue with 100 milligrams. To dapagliflozin, it could be taken as 500 milligrams by mouth in the morning with the first meal to a maximum of 10 milligrams per day. No renal dose adjustment is required. Third medication or a third SGLT2 is empagliflozin, taken as 10 milligram in the morning to a maximum of 25 milligram per day. We should assess the renal function prior initiating. We should not start empagliflozin if the patient has a GFR of less than 45 ml per minute. Last medication in this class is ertugliflozin, taken as 5 milligram in the morning to a maximum of 15 milligram per day. No renal adjustment dose is required. SGLT2s, they decrease the A1C by 0.5 to 1%. Empagliflozin, canagliflozin have increased cardiovascular benefit, or they increase the cardiovascular benefit. They decrease the risk of heart failure hospitalizations. Canagliflozin increases the risk of bone fractures and lower limb amputations. SGLT2s, they increase the risk of UTI infections since they promote glucose excretion in the urine. Okay, now speaking about the DECLARE trial. This trial was published in 2018 in the Lancet Journal, and they studied the effect of dapagliflozin on renal function and progression of kidney disease in type 2 diabetes with a preserved renal function of 85.2 ml per minute. Patients were included if they had type 2 diabetes, if they had established atherosclerotic cardiovascular disease with the age of 40 or more, if they had ischemic heart disease, if they had cerebrovascular disease or peripheral artery disease. Patients were also included if they have risk factors that would predispose them to atherosclerotic cardiovascular disease, which includes men of 55 years or older, women of 60 years or older, and also had dyslipidemia, hypertension, or tobacco use. Another inclusion criteria was the A1C of 6.5 to 12% and the creatinine clearance of 60 ml per minute or more. Now, 17,160 participants were randomized to either dapagliflozin or placebo to a ratio of 1:1. Patients were followed up by phone every 3 months and in-person visits every 6 months. The outcomes assessed were, so the primary outcome was the occurrence of a major cardiovascular event, such as death, MI, ischemic stroke, or hospitalization due to heart failure. And the secondary outcome assessed was the cardiorenal composite outcome, which was characterized by a decrease in the GFR by 40% or more. And it has been confirmed by 2 lab tests that are 4 weeks apart. And the so that the GFR will be to less than 60 mLs per minute. Also, an end-stage renal failure with a dialysis with 90 days or more, kidney transplant, a GFR of less than or 60 mLs per minute or less, cardiovascular or renal death, a one-time decrease in the GFR to less than 60 mLs per minute. The trial took place between 2013 to 2018 with a median follow-up time of 4.2 years. And here's a diagram of the results. So as we can see here, the composite renal outcome and the composite renal specific outcome, as well as the sustained eGFR decrease by 40% or more to a GFR of less than 60 ml per minute, and the end-stage renal disease or renal death. All those, they showed a significant difference favoring dapagliflozin. Oh, also the end-stage renal disease. This one also showed a significant difference favoring the dapagliflozin over placebo. So there were other studies that were mentioned in this same trial. Those studies include the EMPA-REG outcome, which studied the empagliflozin versus placebo for renal disease progression. Empagliflozin showed a decrease in renal disease progression, which was characterized by a development of macroalbuminuria or a GFR of less of 45 mLs or less, starting renal replacement therapy by 39% compared to placebo. Also, the CANVAS trial, which which compared the canagliflozin to placebo, and canagliflozin improved the renal outcomes compared to placebo. There's also the credence trial, where the canagliflozin decreased the end-stage renal failure by 30% compared to placebo. Other oral anti-diabetic agents include the alpha-glucosidase inhibitors, which include the acarbose and miglitol. There's also miglitinides, which include natiglenide and repaglinide. There's bile acid sequestrants, which include colcivelin. There's a dopamine agonist, which include bromocriptine, and there's amylin analogs, which include pramlintide. But those classes, they are not frequently used, so I did not go in depth with those with those medications. And that consists my presentation. I would like to thank everyone that took the time to listen to this presentation. If you have any questions, please reach out to me at 407-388-8997, or you could also email me at Sandy, SANDY, NADIR at hotmail.com. Thank you so much. Have a great day.